Welcome to it. Keith, Respiratory Associates. Always appreciate y'all having me. My name is Chandler. I'm currently a pulmonary disease navigator and respiratory educator. Lasix, furosemide, however you want to do it. We've all heard about it. We've all probably seen it being used. We've probably all had a COPD patient or a CHF patient, and they're just throwing the Lasix at them, or we're going to dry them out, we're going to do all this stuff, right? But nebulized, kind of, wait a minute, right? Tranexamic acid, some morphine. We got some kind of OB, those kind of things. We got some off the wall stuff we can kind of throw in the neb that you don't use all the time. Well, this is something, personally, I've never put into a nebulizer. I keep asking, if anybody has, get a hold of me, right? I want to talk to you. So let's start it here. Respiratory therapists provide therapy to a wide variety of patients and are utilized in nearly every portion of healthcare. So I'm in a hospital, but it's more so kind of like that ambulatory side almost. Many of the drugs and diagnostics used in cardiopulmonary support may be used in unconventional ways. Now, we know also, us wonderful respiratory therapists, we're kind of the MacGyvers, right? We can make it happen. We can get some O's to you. We can ventilate you one way or the other most of the time. Now, this lecture is aimed at reviewing the literature and compiling the most common approaches concerning the use of furosemide as an aerosolized treatment for dyspnea. Now, I will make this disclaimer probably multiple times, but this is not a means for you to go out and start slinging nebulized Lasix to all sorts of patients, right? Now, as we'll find out, this may be something that you can talk to your providers about. But right now, don't consider this as me saying, hey, go out and do that. We've got a couple of objectives here. We're going to review breathing and dyspnea and try to understand it as if we don't already. And you'll say, oh, come on, we know about breathing, right? We're going to dive a little bit further back into it and kind of look at the mechanisms of action. We're going to look at furosemide as it stands as a loop diuretic and, of course, as a nebulized medication, possibly. But I find it important to know how furosemide is working within the nephron, within the kidney, and it kind of helps to make sense of maybe how it'll work in other places too. Look at some possible indications for the use of nebulized Lasix. A starting guide, again, remember my disclaimer, okay? This is a compilation of review of literatures, all those things, right? And then we'll wrap it up with a nice little bow. COPD, cancer, idiopathic pulmonary fibrosis, on and on and on and on, right? Chronic diseases. What are we looking at those, right? What do those kind of all have in common? Many, if not all of them, at some point is going to experience some type of dyspnea, shortness of breath. Now, we think of our COPD, I want you to think of your pink puffers, okay? Now, our blue bloaters, they have a hypoventilation syndrome going on, right? But our pink puffers, no matter what we do, they're just short of breath, right? We can throw the whole book at them, still short of breath. As the diseases progress, this instance becomes more and more common. That kind of makes sense, right? If you have emphysema and you continue to smoke, and of course, as we age, our function declines, it's going to get more and more common, right? It's one of the leading indicators, one of the leading causes going to the ER. Cough, fever, and that stuff. So, how? So we're going to separate the anatomical and the physiological, and we'll look at the subjective. But how's it causing the shortness of breath? Well, we'll see destruction of the elastic fibers, right? Dysfunction of the alveolus as a whole, chemically mediated signal stall, theoretically, genetic alteration at the basal level, at the extracellular matrix, even, impaired gas exchange. And we can see this. So, Gold Guideline has thrown around this PRISM. It's kind of like HFpEF, heart failure with preserved ejection fraction. So this is preserved ratio, impaired spirometry. prison, or grade 0, however you want to call it. So from the very beginning to grade 4 and the end of life, they may experience varying degrees of dyspnea that, like pain, cannot be truly quantified, right? My wife's a nurse, she'll say, we ask patients all the time, what's your pain level? And they'll be sitting there eating their Cheerios, watching Scooby-Doo or something, like it's a 10 out of 10. Well, it's quantifiable, right? Subjectively quantifiable. We can't say that it's truly quantified, right? You go in, you see your patients, maybe you know them pretty well, friendly face or a high utilizer, however you want to coin it. You see them and they're like, buddy, I'm just so short of breath, ain't nothing going on. Say it's great. Of course, you got a blood gas on them. pH is 7.40. That's not to say that they're not short of breath. We can't truly say that. So a lot of times we look at select mechanisms, extrathoracic, pulmonary vessels, heart problems, etc. And many of us know we have muscarinic drugs, sympathomimetic, however you want to call all these different, essentially smooth muscle dilators within the lungs, so on and so forth. But there's a few that we haven't really dove into too well. Some that intrigued me during my studies as an undergraduate and graduate student. I hope that didn't scare you. I'm sure some of y'all have probably even seen this graphic here on the right. Don't let it scare you. We're going to try to break this down slowly but surely and try to kind of make sense of the mechanisms involved with breathing. So let's look at this somewhat intimidating slide here. So this is all breathing. I'm sure there's some nuances or something that I've missed or, something like that, but this is the gist. So I want y'all to raise your hand if you've ever heard of the Prebot-Singer complex. Just kidding, I can't see none of y'all. Maybe you can do it on the thing. I don't know. Well, I never had. That's through 4 years of respiratory and 2 years of graduate school, not including Gen Chem, OChem, Biochem, all those things. Never really heard about it until we got into 400 level biochemistry, and we only just kind of breezed over it for just a second. So anatomically, we can see that it's in the kind of the ventral portion of the medulla. The medulla is the upper spinal column. It's somewhat sitting above and or around our DRGs or our ventral respiratory groups. So what kind of is it? And we'll see maybe why it's sitting around abouts there. Okay. Think of it as kind of the SA node of your lungs, your breathing. Kind of think of it as the SA node. You don't tell the heart, hey, go ahead and increase the rhythmicity or increase the contractility. You don't tell it to do that. Right? It just kind of automatically happens. And that's also very intriguing. Well, the Prebot-Singer is kind of known as the pacemaker of breathing, theoretically speaking. Now, this is one of those situations where they're like, well, it's maybe here, maybe it kind of looks like this, maybe these are the chemicals involved with it, but it's kind of known as the pacemaker. So it's essentially kind of a neural network, again, kind of for early initiation of the inspiratory cycle and respiratory rhythm. And we'll see kind of how it's possibly sending some of these signals to the DRGs, VRGs, and so on. So then we look at medullary control. And note here too that all of these are going to fine-tune inspiratory, expiratory phases, but some are a little more involved than others, okay? So Prebot-Singer's rhythmicity and the inspiratory cycle starting that system. Medullary control, we're looking at rhythmicity. We're looking at basic respiratory generation, okay? We're looking at ventral and dorsal. So ventral is kind of a exhale, inhale, and we can see that the Prebot-Singer, again, theoretically, is kind of setting above that, okay? In our dorsal, this is kind of more so the inhalation phase of neuronic breathing, okay? So the Prebot-C kind of sends those signals. If we're looking at inhalation, really that fine-tuning of inhalation, the Prebot-C and the dorsal kind of work together in this way. And we'll look at another slide here in just a minute where it kind of breaks down the stimulation and inhibition of certain drives within the breathing cycle. Okay. So we'll move on to the Pontane or the Pons. We're looking at intensity and frequency. We say all of these are fine-tuning, but the Pontane system, the Pons system is really tweaking it, right? So we have two systems here. We have the pneumotaxic and the apneusic. So the pneumotaxic, anytime you think pneumothorax, right? Pneumotaxic, I always think of taxi. It's like moving air around. But pneumotaxic kind of limits that inhalation, and we'll look into here. This is neurological control, okay? Not specifically talking about hair and brewer yet, but it's kind of limiting this inhalation. Where the apneustic, right? We all have had apneic patients, I'm sure. I always think this, it encourages inhalation and fine tunes this depth and duration. So when I'm thinking of some type of apneic situation, I'm like, oh, maybe way down in the system somewhere, the apneustic system, there's some kind of disconnect there. Can't encourage this inhalation, right? So that's kind of our neurological control without getting too crazy in depth with it, okay? That's kind of how it all works. These are the main systems involved in the brain that's working with these things. Well, not just those, but we see this with the central chemoreceptor too. So we have central and peripheral chemoreceptors. We work on hypoxic drive theory here. Increases in carbon dioxide or really secondarily increases in hydrogen ions. I'll make a note here too. I don't know if anybody knows exactly what pH is. So we think, oh, the pH is 7.20, they're acidotic, right? pH is nothing but the negative log of hydrogen ions within the body. So when we're looking at, and we will look a little bit more in depth here, when we're looking at central chemoreceptor, really we're looking at the hydrogen ions secondary to it increasing carbon dioxide. And then we move on, and that's dealing with our ventilation. Then we move forward into the peripheral chemoreceptors. And when we're looking at the peripheral chemoreceptors, it's really sensitive to PaO2 is less than 60. You're like, oh gosh, I would imagine that too, right? But if we look at our COPD patients, what are we trying to keep their PaO2 around, right? And that's to influence, we say the quote, the central chemoreceptors have dulled. So we keep our PaO2 decreased, or what is it, 88%, whatever, to increase this drive to breathe. And I'll make another note here too. This is more so theoretically involved with our blue bloaters. Okay. I'll make a lecture about that if anybody's intrigued. So central peripheral chemoreceptors, we're working on acid-base balances here, but then we move forward to the mechanoreceptors. I'm going to kind of touch on the hair and brewer here a little bit. Mechanoreceptors, strange concept. No, I mean, not really. I've learned about mechanoreceptors, but never in this way as it comes with breathing. And this is really going to kind of be the focus of what we're talking about in terms of how we're going to use Lasix, right? But we've got to have this good understanding how this all works. So as I promised, I'm sure everybody has seen this picture, hopefully, or at least you can see this Henderson-Hasselbalch equation coming through. So we know that hydrogen ions cannot cross the blood-brain barrier readily, okay? Carbon dioxide, however, can. So what really happens here is carbon dioxide crosses through, meets water, loves water, right? All the whole body loves water. Very active. Well, water can be reactive either which way, basic or acidic. But these two are hugged up together where they meet carbonic anhydrase and catalyzes the equation even further where we have carbonic acid and bicarb with a release of, what is that? It's a good old proton, right? So we can kind of see here how secondarily our increase in carbon dioxide is going to cause an increase in ventilation. And theoretically, we're talking about how the central chemoreceptors, also found in the medulla oblongata, they dull because they just get so desensitized to this acidic environment that they just stop reading. So there we have central chemoreceptors. Wanted to touch on that. Peripherals can be a little more wonky. Let's look at our stretch receptors real quick. Very, very cool stuff. J receptors, C fibers, these can be kind of used interchangeably, even though they are different. They all kind of serve kind of the same purpose here, right? So stimulation of these sensory fibers is believed to be involved in evoking dyspneic sensation. Is think of our air trapped individuals or our flow limitation or inflation limitation. With restriction, it's hard to get the air in, right? With restriction, it's hard to get the air out, which eventually, if it continues on, becomes hard to get the air in too. And then we have blockages, as we see with cancer and other malicious systems that like that. These are vagal bronchopulmonary afferent C fibers, and weirdly enough, and I always try to make a note here too, they are unmyelinated nerve fibers. Myelination, very myelinated systems conduct much faster. And you would think there is a slow and a fast system here. Again, that's a whole different type of lecture. But relatively, in regards to myelination versus unmyelination, unmyelinated sends signals slower. In regard to your breathing, you'd think that would kind of be opposite. But these are unmyelinated nerve fibers that provide sensory input from airway and lung structures to the brain and so on and so forth. So I always make a little joke here. So stimulation by inhaled irritants elicits prominent reflex responses, including apnea, smooth muscle contraction, and mucus hypersecretion. If you're in the room with somebody and they fart, right, and it just absolutely blows your hair back, there may be a quick period of apnea. There may be some smooth muscle contraction. You may cough and hack and go on, right? These noxious and or toxic inhaled irritants elicit some of these cough reflexes. So let's look at breathing. We'll look at this stimulation inhibition system. So we've got irritant receptors, cough, bronchoconstriction, right? I always say if there's something in your lungs that's not supposed to be there, your lungs' natural response is to water up and shut down. I think it's kind of counterproductive, but it's the way it's protecting itself, right? So we're looking at our irritant receptors, muscles and joint receptors, chest wall, all those things. Then we look at stretch receptors and J receptors, and these are not just prominent receptors in these depicted locations. Stretch receptors, we're looking at lung inflation and inflammation termination, right? You can only take so big a deep a breath before you can't no more. We look at our J receptors, sense of chemicals, again, stretch, pulmonary edema, shallow breathing, bronchoconstriction, mucus secretion, right? Now think about how all of these things may impede your airflow, right? We know you're looking at a ventilator, our peak pressures are going all crazy, all those things. Maybe they need a little bit of suction. Get that mucus out of there. It ain't bronchospasm, it might just be mucus. So let's move over here to the even more scary picture here, right? It's not too bad. So we learned already neurological control, looking at pre-BOT-C, VRGs, DRGs, central chemoreceptors, peripheral chemoreceptors, all those things. And we said that the pre-BOT-Z, which is not depicted here, still kind of like, what is that thing? Not really depicted here. Those two, the dorsal respiratory groups and the pre-BOT-C, talk to each other. All right. So we can see here when we're talking about the inhalation phase, we know that our diaphragm needs to contract downward to create subatmospheric pressures, and we're moving through the gradients, right? So if we look here, and let me get my little pen out, we look, we can see the dorsal, see motor neurons controlling other respiratory groups such as the diaphragm, intercostal muscles, those types of things. So we see how that kind of works. Same goes for our VRGs here. Okay, and we can see how our pneumotaxic is going to inhibit, and see what I'm saying? So big thing here is what we're talking about, these stretch receptors. And you see how these are working on it. So our VRGs, which are stretch receptors, can be stimulatory of, what do? Right, inhalation, fine tuning, that type of thing. Then we look at our apneustic center, and we said that had to do, well, like I said, with an apneic patient. If there's apneic, there may be no stimulation of inhalation. So if we're inhaling too far, there needs to be, quote, stretch receptors, a situation in which we say, hey, brain, stop doing that. I'm not going to let you go any further. So you kind of see how all that works together? I hope you do. Each of these things are stimulatory versus inhibitory of full muscle groups. And it all comes down to, well, I'm not saying it all comes down to, but stretch receptors are a big portion of that. This is probably the best depiction that I could find of how these C fiber stretch receptors are innervated within the lungs. Now, what we're seeing here, of course, is pseudostratified columnar epitheliums. And right below it, and if you breathe, there's torsion, right? There's pressure, there's movement. Hopefully, there's mucous movement, right? And air movement. Do you think it would compress those pseudostratified ciliated columnar epithelium mucosa? Think it would squish them, let them to expand, all those things? Yeah. Definitely, if you said yes, you're completely correct. So we could see here how breathing, inflation, deflation can impact our stretch receptors. All right. So we learned neurological control of breathing, chemical control of breathing, mechanical control of breathing. Okay. Now let's look at furosemide real quick, or Lasix. I was told, and I don't know if it's true, that it's called Lasix because it lasts 6 hours. LOL. I don't know. Maybe somebody can clarify that and go on. But Lasix or furosemide, discovered in roughly 1959 and later released in 1964, belongs to a group of medications known as loop diuretics, and particularly, and we'll learn, particularly we're talking about the thick ascending loop of Henle. And this works by preventing the reabsorption of water back into the extracellular matrix or back into the nephrotic parenchyma. This type of medication most commonly used to treat conditions such as systemic and pulmonary edema, hypertension, right? Hopefully all of us have had a patient that's been on Lasix. Could say 80% of my patients have been on. So with any use of any medication, of course, there's going to be some type of side effect or adverse reaction, whatever. So it may cause dehydration or hypovolemia. I mean, it is a diuretic. But it may also cause hypokalemia and other electrolyte imbalances. Now, thing about electrolytes imbalances and hypokalemia is it's not potassium sparing, it's potassium wasting. What happens when we start to lose our electrolytes? We can convulse, have seizures, we pass out, have cardiac arrhythmia, a number of things, right? It's working on our electrolytes. That's how it's moving all this fluid across, right? It ain't just like strong arming the fluid and putting it back into, right? It's not doing that. But it can cause muscle cramps, weakness, confusion, dizziness, nausea, vomiting, polydipsia, arrhythmia. So I was always told, you puke acid, you poop base. What's the 5 number 1 causes of hypokalemia? Vomiting, 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 and vomiting. Right. So we can see, and the point I'm trying to drive here is how these electrolytes are impacting our care. Can be given PO, IV, or IM. A number of contraindications and precautions, as there is with, any drug, right? So we're looking here at the nephron, or the parenchymal portion of the kidney. Glomerulus, never could say that. The whole time, yeah, anatomy 1 and 2, never could say it, but I can say glomerular capsule, which is also known as Bowman's capsule. This is where if I worked a lot in CVICU, you could ask your CVICU nurses, what's your normal GFR? Which should be about 125, I think, per milliliter per minute cubed or something like that. It's 125, I think, pretty sure it's normal. And they say, well, their map is 60. And that's important because of a map of 60 roughly is going to perfuse and filter through the Bowman's capsule. So as that occurs, of course, it moves to the proximal, loop of Henle, distal, and then eventually the collecting ducts. But we're interested in loop diuretics. Look what it's doing. So that's number 3. So it blocks sodium potassium chloride co-transport. It blocks that co-transportation, increases sodium excretion, potassium excretion, chloride excretion, right? So it's moving all of these electrolytes around. Now, I would have to argue when you're moving bulk electrolytes, especially if you're not paying attention to electrolytes, as a lot of patients do at home and things like that, don't follow with PCPs, that kind of thing, that it can cause some problems. But also, let's look at this. So how can Lasix, nebulized Lasix, help with dyspnea? Okay, we said it was a loop diuretic, increases all kinds of excretion, sodium, potassium, chloride. And these electrolytes work on other electrolytes. So let's say you have a bucket full of nothing but positive particles, and you start to take positive particles out of it. There will be a net negative, right? So think about that as, especially, when you're thinking about repolarization, depolarization, that type of thing. So how can it help? I would even have to argue that, the 50 to 70% of patients, end-stage patients experience dyspnea is even higher than that. I would say 70 to 90%. Because, like I say, that's what's bringing people to the hospital, that shortness of breath, not the rest of it, most of the time, from what I see. So J receptor C fiber, stimulation of these sensory fibers believed to invoke dyspneic sensations. Lasix, nebulized Lasix, is theoretically thought to kind of numb those, put them to sleep a little bit. The mechanism of action within that is still not yet completely known. So we know morphine, it's going to take that sensation away. Nebulized morphine kind of does the same thing, but then you think that those are completely different drug classes. Lasix is known or thought in many cases to kind of shut them down, tell them to hush it up a little bit. We also know that Lasix in general induces certain prostaglandin synthesis. It's made by arachidonic acid, don't worry about that. But it induces certain prostaglandin synthesis, and we can see this as, PGD2, prostaglandin D2, is known as a bronchoconstrictor. That's not good. We don't want that in our COPD patients and things, right? But then E1 and E2 are kind of known for bronchodilation. So if Lasix is inducing some of these prostaglandins, and E1 and E2 are part of that list, if we nebulize, it wouldn't have a direct impact on the lung. Okay, so we're getting there. Blocks certain pumps that can then also waste calcium. So as I said, all of these electrolytes that are moving around will shift other electrolytes around. Right? That makes sense. That should make sense. Positive and positives and negatives and all those things. So it's known to waste calcium secondarily, kind of like really high doses of albuterol don't really waste potassium. It shifts it back into the cell. But we can kind of see how that kind of works, right? Make that connection. Calcium we have to have for muscle contraction. Okay, if you look at the bottom right graph here, this is the sarcoplasmic reticulum. The way that it essentially works is that you're spraying the muscle with calcium, which then, as we see here, reduces the troponin tropomyosin inhibition. When it reduces that inhibition, it increases the stimulation. So we know that tropomyosin, troponin, all those move across muscle fibers to create contractility. So we got to have this calcium to spray across our muscles to be able to move and contract and do all those things. Okay. So if we're wasting it, so we're looking at bronchodilation via sympathomimetic agents and parasympatholytics, right? So we can do that. We can do that almost directly. But then there's indirect. Right? How do you ever think that beta blockers impact the lung and adenosine and all those things? There's something going on there, right? So if we can somewhat secondarily, locally, shift that calcium around, would you not think there would be some type of what was at one point an irreversible bronchodilation, but now since you shifted that calcium away, that there may be even further smooth muscle relaxation within the lung? Right. As we noted earlier, stimulation by inhaled irritants in regards to C fibers elicits prominent reflex response to apnea, smooth muscle contraction, mucus hypersecretion. So we see, for instance, with our COPD patients, they're hyperinflated all the time. They're just stretched completely out. I would have to imagine that these C fibers are screaming, you need to breathe out because we're so short of breath right now. And that's not to say there's not some type of chemical mediated signal sent from high CO2s and that type of thing. We're looking at stretch. If we're looking at stretch and we're stretched completely out, they're just going to keep screaming, hey, you are short of breath. Keep moving it around air, right? What does some literature say? Aerosolized Lasix has shown to improve pulmonary function testing, and I should put it in here, but if I'm not mistaken, that was up to 11% increases in FEV1 versus salbutamol and saline versus Lasix and saline. Salbutamol being, I think, 7%. I can send whoever wants the references for that. But it's shown to improve pulmonary function testing. If we're causing a new type of bronchodilation on top of the bronchodilation that we already have via calcium, quote, wasting, prostaglandin synthesis, things that we're not providing to the patient right now, do you think that there would be an increase in baseline lung function? Probably. Right? Researchers state that the addition of inhaled furosemide to traditional therapy for COPD, oh yeah, 11%. Yeah, 11%. Dysregulation of these receptors has been noted to increasing sputum production, increase sensitivity to cough. So if we're having, just like I said with the ventilator, right? If we're looking at our ventilator, we got these peak pressures, and our waveforms all jiggly looking and whatnot, we're probably gonna think maybe they need a little bit of suction, right? Maybe they need a little bit of suction. Because why? Because that's causing airway obstruction, right? If we have this chronic situation and we see chronic bronchitis thrown in with emphysema almost 90% of the time, probably. If we're having this chronic mucus production, be it clear, blue, green, yellow, purple, whatever, the sole purpose of hypersecretion, and now we can get rid of it, wouldn't you think, we dry them out a little bit, that their PFTs would increase? Probably. Do you think that the sensitivity to cough would be as bad? Well, if we're kind of hushing up these stretch receptors, these J receptors, C fibers, all involved with evoking cough and all those things, we're telling those to kind of hush up a little bit. I don't say that will manifest in a PFT, but definitely should make the PFT a lot easier. How many of y'all have done a PFT and your patient just cough horrendously through the whole thing? So we kind of said, we went over Lasix, how it works in the kidney. The point of that was to show you how these electrolytes are playing such an important role and how moving those around can impact other things, right? It's not just a localized effect. So if we nebulize and try to do those things within the lung, there is a mechanism of action that we have not yet introduced into the lung for, again, smooth muscle relaxation, bronchodilation, so on. Decreased mucus secretion, all those things. When might we use it? You say, well, Chandler, buddy, all that sounds okay, but you also said don't go slinging Lasix, right? Don't do that, not on my whim anyway. So when might we use it? So we look at the palliation, hospice care, palliative care, because end-stage terminal patients who are super chronically short of breath all the time is these folks, right? If I'm not mistaken, the COPD Foundation states that by grade 2, a patient should be introduced to palliative care. So anyway, benefits and goals of palliative care. So physical, psychosocial, spiritual. So we're working on the physical relief, pain, manage symptoms, and discomfort. That's what we're talking about with the whole Lasix thing. If we can manage symptoms and discomfort, dyspnea being a terrible discomfort, if we can manage those things, do you think their psychosocial, even outside of what's listed here, is going to be better? They're going to potentially feel better, right? Potentially be able to go out and do stuff, which is tremendous for some folks. I had a patient just recently that was bedbound for 8 months, finally getting them into rehab, bedbound for 8 months. Do you think them getting out and doing things making them feel better? Absolutely. Right? And the spiritual, we can look at this too, is, you go to your spiritual congregation, so on and so forth. But you see how all that kind of plays into the whole quality of life thing? When can an approved drug be used for an unapproved use, unapproved modality at that? So, from the FDA's perspective, once the FDA approves a drug, healthcare providers generally can prescribe the drug for an off label use if they believe it is medically appropriate for their patient. I am no insurance guru or nothing like that, but this has been stated not too long ago. February 2022, U.S. Court of Appeals states that, hey, Medicare, you got to provide coverage for it. So if we're in the hospital or something like that, and I have very close contact with our palliative services, and I'm going to try to get something worked up with this stuff. But I could go up to doc or the provider and say, hey, I think this is going to work. I think this would help with the patient. It's then up to them, and they can legally do so to enact. Okay, well, let's try. Of course, if the patient is, all that stuff is in line. Seems like a lot of work, but when you get a patient that's sublingual, that sublimates, sublingual morphine and whatnot, you can even read in the notes substantial improvement in dyspnea. Go through all that work, and you go through the notes, say patient is given aerosolized Lasix, and there has been a substantial improvement, or even just a little improvement in dyspnea, shortness of breath. And in this lecture, you can click through here and go to those hearings or readings or whatever the court calls it. So here's what I've gathered. Again, don't print this off, slap it up on your department thing and say, hey, this is what we're going to start doing. Chandler said it was good to do. Okay. Here's some guidelines. Some of your physicians may have never heard of, well, where do we start? What are we going to do? If I agree to this, where are we going to start? And say, okay. So let's look at the indications. Indications should be pretty clear by now. Lasix could be considered in patients with severe dyspnea that is refractory to the standard of treatment, including opioids. Well, you say, Chandler, buddy, let's just use morphine. This sounds so much easier. Well, I've also had patients that kind of revoke or go back against their hospice care because the morphine was too much. Maybe, in the patients, they'll say, I don't want to, I can still get up, move around a little bit. I don't want to be so drugged up that I can't do any of those things. That limits interaction with family, that limits interaction with the environment, so on, so on, so on. And of course, in many, many cases, it works out just fine. It's the perfect dose, right? But refractory to all of those things, okay? You can only give so much morphine before they just go to sleep forever, right? So, advanced cancers, post-op patients, severe COPD, including asthma, especially, if we're looking at the labutalol or something like that, Lasix albuterol mix or something, especially with our asthmatic patients. Advanced congestive heart failure, ooh, right? Imagine. So Lasix is pretty nephrotoxic. So imagine, right? You've just beat this CHFer's kidneys up bad. And they're like, oh man, we can't give you a higher dose of Lasix. We're worried about your kidney function, but we can continue to give you this low dose. Well, what about if we nebulized it? Will it work the same? Well, the studies that are here now kind of state a little bit. Let's look at contraindications real quick. No contraindications for aerosolized Lasix as of late. Again, these are pretty small since it's not 30,000, 40, 50 million people sample size. It's nothing like that. But as of late, no real contraindications right now. The better practice is to follow the contraindications for PO, IV, whatever routes, and abide by those guidelines. And use your clinical judgment, of course. If their potassium's 1, they probably did, but if their potassium's 1 or something, you probably don't want to be like, hey, let's try to nebulize some Lasix, right? Common dosages, from what I found in the literature, pretty broad, really. But 15 milligrams to up to 120 milligrams, dilute several different ways. Commonly, what I've seen kind of across the board is, is say, oh, well, this patient was given 20 milligrams. They said it didn't work, so we gave them 120 milligrams the next time. But generally, what I'm seeing is 20 to 40 milligrams diluted in 2 to 4 cc's of normal saline is common practice. I won't say common practice, but Here too, the nebulizers that were used in these studies were kind of standard. Some were breath actuated, some were continuous flow. Me personally, if I was going to do this, and hopefully I can enact something where I can start to do this a little bit, maybe I'm going to want a filtered neb. Maybe I'm going to want to take all the precautions I would need for, aerosolizing antibiotics or something like that. No particular, they weren't like vibrating mesh nebulizer or nothing like piezoelectric, none of that stuff. Just kind of general nebs. Higher doses have shown to increase the urge to urinate and may aid in diuresis. Now, it would take 50 blue million years to come back with a study that says, oh, well, the lung stuff's causing nephrotoxicity too, right? It'll take a bunch of studies to show that. But right now, it's just like, when you're smoking cigarettes, I don't smoke cigarettes. People that smoke cigarettes, very common cancer from smoking is bladder cancer. So that's the point I make to a lot of my patients. And I'm like, it's circulating your whole body. And we have to remember that here too. But hopefully not direct insult to the kidney in this way, right? So side effects and adverse reactions. Transient nausea was noted, sleeplessness and pharyngeal irritation. The nausea, what it's going to give for that? Zofran or something, right? I think a lot of my patients are on nausea medication. Sleeplessness, I can't really account what that may be. I don't know if there's sleeplessness in IV Lasix or any of that besides having to get up and go pee a whole lot. And pharyngeal irritation, I could probably see that one being one of the most common, just because, it's just like I tell my patients with albuterol or anything else, it can't taste great. Some of them, when they take it, they cough a little bit. It's probably a little bit of an irritant, right? So pharyngeal irritation, if you can take whatever part of the Lasix chemical compound, whatever part of that, you just break it off and get rid of the pharyngeal irritation, right? I think it'd be all right. So it was noted in one small study, and I'm not, that's the thing, I want to present the good and the bad too. So it was noted in one small study that patients actually suffered worsening shortness of breath. However, it was not significant. Now, I want to bring back to this too, that the majority of the studies that are out there are showing benefits from Lasix. Just like pain, shortness of breath cannot be truly quantified, right? A lot of this comes down to samples, who your patients are, and so on, right? However, suffered worsening shortness of breath that was not significant. Okay. Diuresis and the urge to urinate increased in some patients, again, was not significant. No other complications were noted. Benefits to this. Well, improved quality of life, for one, right? Improved functional capacity. So let's kind of backtrack here real quick. If this is truly, and again, a lot of this is still theoretical going on, something's going on that's beneficial. But if theoretically, if we are increasing our airway lumen, improving our PFTs, and decreasing our airflow limitations, would not our quality of life and functional capacity increase? Wouldn't you much rather take nebulized Lasix twice a day as opposed to have to wear it around Life 2000, for instance? Right? And there's just different comparisons, but you know what I'm saying, right? Improved quality of life, improved functional capacity, decreased lengths of stay. Big one here, folks, right? So, well, decreased lengths of stay and decreased readmissions. So my job is to work with these high utilizer friendly faces, whatever you coin them, and figure out what's going on. Can't you get to your medicine? Can't you afford your medicine? Is the wrong medicine? Let's do a PIFR. Let's figure it out. Folks, please do PIFRs on your patients for the love of it. I correct probably 50 of those a month. But decrease readmission. So I told you all that it's not really the cough, the sputum production, the fever, malaise, none of those things, right? Because you ask your patients, what brought you to the hospital? They're like, buddy, I couldn't breathe. Well, how long has it been going on? Some will tell you 5 days, some will tell you 2 weeks, some will tell you today. It's that boom, that shortness of breath that they can't get rid of, even if they're coughing junk up, right? Take me to the hospital. Panicking, take me to the hospital. So the pandemic we see with COPD and other chronic lung diseases, particularly, is that of dyspnea. More often, it is that which the patient presents to the emergency room or the clinic. Most of the time, the emergency room. It's not generally the cough, sputum, the periodic increases in oxygen. I mean, these folks are going to their outpatient pulmonary like I was on 2 liters, now I'm on 4 liters. It's not that, right? It's not that they went from 2 liters to 4 liters, went home the same day and had to go up to 5 liters, depending on the concentrator. It ain't that. I had to go up 6 liters yesterday, but it came back down. It ain't none of that stuff, right? Shortness of breath. The idea of bronchodilation at its roots is that of quality of life. We know that there is a loss of lung function, and it's the job of the bronchodilator to keep the function as high as possible. Now, I'm not going to say that Lasix is a sympathomimetic, parasympatholytic. I'm not going to call it any of those things. It's a loop diuretic, right? That's what it is. But it's showing, in some cases, subjectively, for shortness of breath, but it's showing objectively to be improving some things in terms of bronchodilation, improved exercise tolerance. The less dyspnea a patient experiences, the less likely they are to want to stay in a facility. So your hospital just rolled out nebulized Lasix or whatever other brand name they want to call it. They roll it out. High utilizer comes in, say, oh, I gotta have that A&A, buddy, right? Gotta have that A&A. Because they know like our terms, right? Give me an A&A, give me a Dewey Neb, put my CPAC on, oxygen. But they come in, you're like, well, no, we're going to nebulize this Lasix and we're going to see what up. And it works unless they're there because, you know, they have terrible family or terrible place to live, something like that. If they're just there solely for shortness of breath, they're going to want to go home. Probably immediately, right? Oh, I'm good. Get Savvy at me. This row. I don't need no Savvy-Medrol. So the less dyspneic a patient is intra-facility, the less likely they are to want to stay there, quote, an extra day. For us, RTs, it's another cog in our belt, another tool that we can pull from and say, oh, Duaneb's not working. They're at home Bravana and Upilry and Pulmicord's not working. Okay, cool. Let's try this. And folks, it's another look at shortness of breath. As I said, we can look at all of these other mechanisms, but this one is very intriguing. Consensus, again, I'll say, nebulized Lasix has not been studied in depth enough to make recommendations at this time. Furthering the research and targeting the right patient population may yield a broader scope of practice for respiratory therapists and alleviate the feeling of shortness of breath and increase patient comfort in those that suffer from end-stage cardiopulmonary disease. You probably need to break that sentence up, right? More high-level evidence is needed. Okay, note that. But the evidence that we do have is pretty reassuring. Okay, let's wrap it up, y'all. Lung disease. Lung disease impairs the quality of life and presents with subjective dyspnea. I'm so short of breath, I can't even talk, but they won't stop talking. Subjective dyspnea. This dyspnea manifests via our chemical and electrochemical neurological functions, as we talked about. If breathing occurs there, dyspnea likely can occur there too. Neurologic control of ventilation is complex. That will take literally probably 2 hours PowerPoint to get through the intricacies of even oxygenation control. We look at the electron transport chain. More attention may be needed to really focus on the root cause of dyspnea. We think here lean thinking, why, right? The 5 whys, what have you. Lasix is a loop diuretic that is generally used to remove fluid from the body. Theoretically, aerosolized Lasix impacts the stretch receptors of the lungs. As I said, kind of puts them to sleep a little bit. Intrigues me as to what other routes can be used for dyspnea, how it can impact our scope, not just smooth muscle relaxation or anti-inflammatory medications. There's not a general consensus, but a review of literature. I mean, there's quite a bit of literature, but the sample sizes are small. It can increase PFT values, which may further explain the alleviation of symptoms, increases in quality of care, exercise tolerance, right? Folks, I appreciate y'all. Keith, appreciate you. I'm going to hand it back to you. Thank you.